All right, so thank you very much for this invitation to talk to you this morning. Some months ago, Dr. Brown emailed me, and this was what the content of the email was. We regularly operate on patients with brachial plexus injuries, with no function in the arms, cervical spine injuries, with no motor function below cervical level, both acute and chronic, and patients with hemiplegia. Each faculty seems to have different approach to paralysis question. In the end, surgeries require full reversal of any paralytic, as we must stimulate the nerve to make intraoperative surgical decisions. So based on that, today I'm going to talk about the denervation states, how the response to muscle relaxant changes. And I've titled my talk, Aberrant Pharmacology of Muscle Relaxant in Patients with Neuronal Palsies. I have no conflicts of interest to declare, except that I have current and past funding from the National Institute of Health and Shriners Hospital Research Philanthropy. I must apologize also that quite a lot of the slides I'm going to show you are somewhat dated, because I have moved on from this area to another area, which is critical illness-induced muscle wasting, and therefore some old slides, but they are still relevant, and there is not much new about it. And I'll tell you all I know. And this is just an outline of the questions or discussion that I'll provide. Conditions with propensity for succinylcholine hyperkalemia, which also seems to be associated with the resistance to non-depolarizing muscle relaxants. Now, I'll give you examples of the clinical phenomenon. And I'll also talk about the normal and denervated muscle morphology, mechanisms of these aberrant responses to relaxants, both depolarizing and non-depolarizing, and management of the aberrant responses to muscle relaxants in these patients. So when I talk about the neuromuscular junction or neurotransmission, I like to show this Michelangelo's masterpiece, which is there in the Sistine Chapel. It's called The Creation of Adam. This God looks like he's coming out of the clouds and trying to give life to man, but Adam is already fully formed and awake and alive. Is there something else that is being delivered by this painting by Michelangelo? He started painting when he was 13, and by 18 he was dissecting bodies also. Here is a sagittal section of from Netter's anatomy book, indicating the brain and the hypophysis and the spinal cord. And this is an outline of Michelangelo's drawing in the Sistine Chapel. Does it mean, I forgot to mention that this particular figure, all the angels and Adam have all the toes and fingers except 2 angels where the toes is truncated. What is that? Is that reflecting the hypophysis and the spinal cord? By this drawing, is he saying that God not only is giving life, but also intellect to man, and he is providing this to Adam without even touching him? And that is neurotransmission, or deo-transmission, I would call it, because God is giving life and intellect to man. So that's just a side show I just wanted to bring to you prior to this. So the main, before I start on the individual responses, I just want to give you a pharmacological dictum associated with the receptor number change. Here's the dose response curve in a mature adult receptor. If you give a muscle relaxant, there is a response, and there is a peak response, and full paralysis occurs. In the presence of increased receptor number, as it occurs in denervation, the response to an agonist drug, agonist, succinylcholine is an agonist because it depolarizes or stimulates the receptor, the response is shifted to the left, or you get less, you need less of the drug to get the same response.
Can I ask a clarifying?
Of course, anytime you can stop me.
Thank you so much. This is, you're talking about the muscle denervation.
Yes, muscle denervation
Right.
or
So we're
any
not talking about
denervation.
anything central right now. We're talking about a peripheral loss of the lower motor neuron.
Yes. But it can also be upper motor neuron too, of course. So, but I'm talking about any denervation. If you denervate the heart, the beta receptor numbers go up.
Okay.
So any denervation causes the receptors to go up. So in this case, if the denervation occurs upper or lower motor neuron, the receptors do go up, even with upper motor neuron injury. So the acetylcholine receptor or succinylcholine response is shifted to the left, or you need less of the drug. In contrast, if you give an antagonist, you need more of the drug because there are more receptors. But there are additional factors. There are qualitative changes also occur which causes the resistance, and I'll talk more about it. What are those conditions where there is upregulation of receptor? Increased receptor numbers occurs in upper or lower motor neuron injury, burn trauma, direct muscle trauma, disuse atrophy. In some of these, although there is no nerve injury, there is still an upregulation of receptor. Disuse atrophy, there is several studies indicating upregulation of receptor. If the muscle is stopped from contracting, the body or the muscle senses that as if it's denervated and therefore upregulates receptor. Prolonged use of muscle relaxants, as in the ICU for ventilation, severe infection and clostridial toxins. All of these are post-junctional. Clostridial toxin by its action on the pre-junctional receptor, preventing the release of acetylcholine causes denervation-like state, and that's caused, or if you inject Botox, that's what happens to patients if their muscle is paralyzed because of pre-junctional block. In these instances, there is resistance to antagonist drugs such as rocuronium, pancuronium, D2 Vecuronium, the first drug, or in hyperkalemia to agonist succinylcholine. Conversely, if there is a downregulation of receptors, neonates and infants who have decreased receptor number, myasthenia gravis and cholinesterase inhibition, either due to nerve gas inhibition, organophosphate poisoning, or iatrogenic, pyridostigmine was given to soldiers who went to the Gulf War as prophylaxis against organophosphate poisoning, and those patients can demonstrate and have demonstrated myasthenia-like syndrome because of the downregulation due to persistent stimulation of the receptor. But we'll talk more of this upregulation. So I got interested in this area when I was anesthetizing burn patient. Here's a D-tubocurine is an old drug. Some of you have never used it. If you give 2 doses of curare, each line refers to one which site the ulnar nerve is stimulated and the recording of the thumb adduction is recorded here. With 2 doses of D-tubocurine, the patient is paralyzed or the adductor is paralyzed. In the burn patient, 2 doses does nothing to him. And we had to give about almost 4 times the normal doses to get the same effect. And we measured concentrations in plasma. They required about 3 to 5 times doses to get the same effect. So antagonist drug. Not only D-tubocurine, Vecuronium also does. All the drugs do this. This is a controlled dose response curve to Vecuronium. If you have a 20 to 40% burn, it's shifted to the right. 40 to 60% burn is further shifted to the right. All these studies were done 1 week after burn injury or more. At 60%, it's still the same. It doesn't increase further. It behaves like a 40 to 60% burn. It doesn't occur in the first week, or very difficult, or you rarely to see this. So there is a critical mass has to be developed to see this effect. So there's a time-dependent and an intensity or injury-dependent response to antagonist drug. In order to study this, we turn to natural ligand because Western blot was just not available for these drugs. So most people resorted to naturally occurring ligands, muscarinic receptor, acetylcholine receptor can be muscarinic or nicotinic. If you are studying muscarine, you can use extract from Amanita muscaria or from Atropine belladonna to study muscarinic receptor. If you are studying nicotinic receptor, the ganglionic receptor used nicotine. For the muscle receptor, we used the cobra toxin, alpha bungar toxin, a radio-labeled toxin, to determine by grinding the concentrations of the drug by grind and bind experiments. So here is the burn patient that we studied 9 days. Normally it's about less than 5 femtomole per milligram protein. Within 9 days, the receptor number is increased and then even peaks at about 106 days, and gradually with the recovery of the burn wound, the receptors come back to normal, but it's still there, even because it's a big burn, it's still there even 1 year later. But I feel that at this point, there isn't a critical mass to cause hyperkalemia or resistance, or maybe resistance, but not hyperkalemia. We next studied a denervation, what happens to it. This is a rat study where we partially denervated one side, the left leg, and did not do anything to the right side, or like sham denervated, and gave muscle relaxant. And
this is a sciatic nerve injury?
Sciatic nerve injury, yes, partial denervation. As you can see, the sciatic nerve, because of the denervation, could only produce a 10-gram tension, a weaker muscle, a 50-gram tension on the normal side. The relaxant is given, the concentration is the same on both legs, both sides. The normal side, the stronger leg, is paralyzed, completely paralyzed. The denervated leg is not paralyzed and recovers very much faster. A weaker leg is recovering, is more difficult to, as intuitively, it's counterintuitive that a weaker muscle requires more paralytic to get the same effect.
In which paralytic agent is this?
This is Bured. So this was the drug. Like study was done quite some time ago.
Antagonist.
Because the reason we did that was because we had the assay available for Curare.
Okay.
All right. It will be the same for any denervated state. And we looked at the concentration. Here is a control rats, the concentration. As the denervation, because of the denervation, they increase the receptor number. And there is a direct correlation between the receptor number and the effective dose of D2-Bured, with an R squared of 73, which means 73% of the variability explained by changes in the receptor number. Sorry. This is a study with disuse atrophy. Nerve is intact, but just simple disuse. A time-dependent shift in the dose-response curve to Vecuronium, a short-acting drug which would have been very useful for your patients. Unfortunately, it lasts only 15 minutes. But unfortunately, FDA has not withdrawn it, but the drug companies are not producing it and not available. So a shift in the dose-response curve, a time-dependent, 2 weeks, 4 weeks, and 6 weeks, and same response to Vecuronium, a time-dependent shift in to the right in the dose-response curve with disuse atrophy. Most likely, although these people did not do assays for the receptor, but others have shown that disuse atrophy, including ourselves, that there is an upregulation of receptors. This is a human study from Colombia where they studied hemiplegic patients and studied the weak arm, the hemiplegic arm, and compared it to the contralateral side and the control non-hemiplegic normal patients. Again, the paralyzed side requires more muscle relaxants to paralyze it. And even the normal side, so-called unaffected arm, seems to be resistant. Is this related to the disuse, or is this related to the mini stroke that the patient had previously? It's difficult to know. We don't know that. They didn't explain it. But not only is the affected arm increased, even the normal, so-called normal side is affected compared to the normal side. So this is an important message because your monitoring of the patient on the normal side might not reflect what is going on with the diaphragm, because even that side seems to be resistant, whereas the diaphragm may not be resistant or may be resistant too. We don't know that. So this is a depolarizing relaxant response in ICU patients. They used two different types of relaxant, succinylcholine and Impretil. Was never available in the US. This is a German study. Not every patient has a hyperkalemic response. Earliest is in this patient at 7 days. But of course, more and more patients respond with hyperkalemia as time goes on. And these are ICU patients who are also have systemic inflammation, infection, and also immobilized and or ventilated. They didn't differentiate. All those details are not available. It's a very old study in burn patients. Again, burn patients those days were not taken to the operating room early enough to go, so there was no information available. They waited, the AChRs separated, and then only took. Nowadays, we take them early and do early surgery, but those days they did not. And here we have, again, not every patient gets hyperkalemia. This particular patient has just a one-arm burn, but a severe burn, electrical injury affecting the whole arm. And at 40 days received succinylcholine, has the high response to succinylcholine, a hyperkalemic response.
Do you think that is related to the fact these electrical burns seem to have more of an internal body mass as opposed to surface burns of the skin? In fact, that his muscles have been
as you know, the bone is the most resistant to electrical conduction. And therefore, when electricity flows through the body, the bone gets heated most, and it's the muscle around the bone that gets destroyed more.
Okay.
And actually, relative to bone, the skin and fat are better conductors. So the muscle is really destroyed by the heated bone.
Okay.
So this is our own study by Dr. Yanis, who was a HMS medical student. He did this while in medical school, and he went on to Mayo Clinic, did neurosurgery, and it's been private practice in California. So this is his study where he infused D-tuberculin to mobile animals. This could be done because of the margin of safety of excellent margin of safety of neurotransmission in rodents. So he subclinical dose of D-tuberculin were infused in mobile animals through LZ pumps. And one leg was immobilized, and immobilization together with infusion of curare was given to these animals. And the acetylcholine receptor number quantitated in muscle compared to control. The infusion of curare increased the receptor number, immobilization increased it more, and the combination further increased it. So double hit is a more profound upregulation. And the peak response to potassium drawn 5 minutes after succinylcholine shows a parallel response to receptor number. And that is indicated by this Pearson's correlation coefficient curve. Control animals, curare-infused animals in green, immobilized animal in red, and the double hit in yellow. Direct correlation between receptor number and potassium change. So here is a Clostridial toxin patient who received succinylcholine. This is not my study, but I published this paper from another study. The study was done those days, about in 1975, where following succinylcholine, they monitored the potassium response. Of course, these days, these studies are not possible because human studies will never allow us to do this. Within 2 minutes, you can see the peak T waves occurring with the potassium rise. And after 5 minutes, when the potassium reaches 9.2, there is ventricular tachycardia. And then at 23 minutes later, with continued cardiac resuscitation, they defibrillated. And at which point, when the potassium was 7.2, the rhythm came back to normal. And then by 24 minutes, the potassium was normal. Of course, it was being treated with calcium and other drugs, which I'll give in a minute, what the treatment was, or what is the normal treatment for this sort of response in case somebody gives succinylcholine inadvertently. So I just want to go over the receptor changes that occur in the fetus with maturity and again in the pathological state. In the neonate, in the fetus, prior to innervation, the acetylcholine receptor are spread throughout the muscle, and the receptor isoforms are different compared to the mature receptor. The receptor, there is an immature receptor identified by the gamma subunit expression, exemplified by these two receptors, is also an alpha-7 receptor expressed in the neonate. Once the nerve is inserted during the fetal life, just prior to birth, the nerve starts coalescing together around the nerve. And by birth, they are all together, but not fully mature, but within 2 weeks, the nerve and the receptors are opposed together completely, and there is no extra junction receptors at all by 2 weeks in the rodent. And the receptor isoform is now different, identified by the epsilon subunit expression together with the alpha, beta, delta. However, in any pathological state, critical illness, disuse, denervation, upper or low motor neuron, it reverts back to the fetal form, or somewhat to the fetal form, where the closely opposed receptors are now dispersed and again are spread throughout the muscle. We also identified and demonstrated that in this state, the alpha-7 is re-expressed, both junctionally and extrajunctionally. The extrajunctionally, only the gamma subunit is expressed, whereas in the junction, the alpha-7 is also expressed in the denervated state. And this again takes not a few days, but probably at least a week for the critical mass to occur for the succinylcholine to happen. Actually, of course, I should say there is one case report of a head injury patient who was also intubated and ventilated, who received succinylcholine at 4 days after the head injury, got hyperkalemia. So there is one report, but most reports are 10 to 14 days after some sort of inflammation or injury.
And so these receptors aren't grouped, they're dispersed throughout the muscle.
All over the place, just like the fetal form. Just as if it's denervated, despite the presence of the nerve, they are expressed all over the place.
We're always having discussions about, reinnervating muscles in the chronic stage, and people talk about the motor end plates having degenerated and so forth. But if these receptors are everywhere, that theory that a motor end plate can arise as long as an axon sort of makes connection with the muscle seems to be supported. It's just diffuse throughout the muscle, huh?
Yes, but once the nerve is inserted,
yeah,
it usually goes back to the same original site of innervation most times.
Okay.
And of course, as you know, there can be multiple innervations too in some of these states.
Okay.
So what is the mechanism for the hyperkalemia? In a normal state, these are localized here. Although succinylcholine is bathing the whole muscle, it just depolarizes only the junctional receptors. And therefore, the potassium release from the muscle to the outside is very limited. In contrast, when the receptor numbers are spread throughout the muscle, not only the junctional receptors, but all the extrajunctional receptors release potassium. And there is a concentration gradient, as you know. The potassium inside the cell is about 140 compared to 4 outside. So the moment it is depolarized, there is an efflux, massive efflux of potassium from the cell outside. And that's why it takes about 2 minutes for the peak to occur. So the massive influx, and then it goes to the circulation, and this is what causes the succinylcholine hyperkalemia. There are some qualitative changes also in these receptors which exaggerate this. This is a mature receptor. If you depolarize it, it opens and closes within 10 milliseconds, sorry, in 1 millisecond. In the immature receptor, which has the gamma subunit, once you depolarize it, it stays open for a longer time. So there is a longer time for the leak to occur when the immature receptors are expressed.
So allowing much more potassium release.
Of course, for much more potassium. And also, this particular receptor can be depolarized with 110 to 100 doses of acetylcholine or succinylcholine. So even although the succinylcholine concentration is going down with time, they continue to be depolarized because they are more sensitive agonists to this agonist because of the receptor isoform change. That has been demonstrated more than 30 years ago by basic scientists, by electrophysiology. So this is taken from a review by other studies about the receptors of the low conductance or the high conductance channel in the mature, whereas the low conductance and longer open channel time in the immature receptor. The alpha-7 receptor also has different properties. It has 7 alpha subunits, and that is why it's more difficult to block these receptors, because even if you block these with 3 non-depolarizer receptors, there are 2 alpha subunits still available to depolarize that receptor. It's more difficult to block this, but this receptor can be depolarized by succinylcholine, its metabolite succinylmonocholine, but also by the choline, which is a metabolite of succinylcholine. So it's a concentration dependent. A 10 millimolar will depolarize it to this level. A 30 millimolar will have a higher depolarization, leaving it. And it doesn't desensitize. It just continues to be open as long as there is enough sufficient choline levels. So the expression of mature receptors and the alpha-7 receptor is explained not only by the receptor number, but also by the qualitative changes in the isoform and their behavior during depolarization. So what do you do if you inadvertently give succinylcholine? Calcium salts, calcium bicarbonate or calcium chloride, either one is all right. And you have to give repetitive doses, because once you give it, it dissipates very fast. We have to give repetitive doses based on the EKG response. It's very difficult to measure potassium levels. If there is cardiovascular instability within 2 to 5 minutes of succinylcholine administration, always think of succinylcholine as a potential cause. And you can look at the EKG and you see peak T waves and calcium salts, and then epinephrine infusion together with epinephrine infusion or bolus or albuterol intratracheally has been used to drive potassium back into the cell. Sodium bicarbonate, alkalinization also drives potassium back into the cell, and then glucose infusion together with insulin. This takes a longer time. These two work. For calcium is the best. Epinephrine also takes time, but a little faster than bicarbonate. Bicarbonate is useful, and glucose infusion takes at least 20 minutes, but should be instituted. The polystyrene sulfonase, which we use in kidney failure patients to excrete potassium, that is too slow, usually not used, and it's not used, I think, in continued cardiopulmonary resuscitation. Sooner or later, they will come back as long as you resuscitate them for a while, because the potassium is driven back into the cell and the patient survive if you continue resuscitation. So these are resuscitatable patients, not like a severe cardiac arrest due to other reasons. So when can we give succinylcholine? As I said, there is one report indicating 4 days later causing hyperkalemia following head injury, but most reports are 10 to 14 days later. So we say that it's safe to give succinylcholine after upper or lower motor neuron injury up to about 72 hours. And after critical illness or burn injury, we think it's safe to give succinylcholine unless there is continued contractures and immobilization because of the injury, which would mean that still they are immobilized and upregulated, therefore not safe, or if there is evidence of proteolysis. Because all of these conditions, there is proteolysis going on, and that all this causes these changes. Spinal cord injury, we think it persists for a long, long time. There is one report at least of one patient getting succinylcholine 10 years after injury because of laryngospasm, and they gave a smaller dose, 20 milligrams, and had a cardiac arrest and was resuscitatable, and he came back. So we think spinal cord injury patients should never get succinylcholine. And that is consistent with their heightened autonomic response, because if you pull on the bladder or cause some pain, the autonomic response is still there, even 10 or 15 years later, because the denervation state, their beta receptors are increased, and even small release of catecholamines can cause a heightened response, and that explains the autonomic response of the spinal cord. So similarly, the spinal cord injury, we think they will respond even to small doses of succinylcholine with hyperkalemia.
And do you think that matters, the level of injury? A cervical versus a mid-thoracic would respond the same?
I would think so. A cervical would involve more muscles, and therefore more of these receptors will be upregulated. I would think that even at the lumbar level, it might be dangerous.
Interesting. Okay.
So I talked about the resistance. Here is, again, most of the information is coming from my own studies in burn patients. In a control patient, you give Vecuronium 0.9 milligrams. You can get full paralysis in about 60 to 90 seconds. You give the same dose to a 40% burn patient. It takes at least 150, 180 seconds. And that's not good enough for rapid sequence induction if they are full start. We increased the dose to 1.2, it shifted a little bit to the left. We gave 1.5, it increased it further to the left, but not as good as control patients. So increasing the dose can make the onset faster, but not as good as the non-burn patient. And I would think that this would be the same in patients if they have hemiplegia and immobilization, that there will be some resistance throughout the body. And therefore, one has to give slightly higher doses. But you can give Vecuronium higher doses, and fortunately, you can give Sugammadex, which is available, which reverses the drug very fast. Within 2 to 6 minutes, it can be reversed. It binds the drug, and there is no recurrentization. It's all eliminated. Even in renal failure, there is no recurrentization. And it's a drug that can be used in your patients if somebody wants to use Vecuronium, and can be reversed rapidly with this drug, and it's available in the pharmacy at MGH.
Yeah. We like that a lot. In fact, most folks are giving small doses of Vecuronium to start our cases. And there have been a handful of cases where I have a finding different than what I expect, even though they've got all the twitches on the anesthesia side. But suddenly Sugammadex is given, and everything then responds beautifully, you know, within just a couple minutes after Sugammadex. But it's interesting to see that the train of 4 response does not correlate with all the nerves stimulating as they should.
That's because there's the anesthesiology is stimulating the normal side, and you're stimulating the denervated side, and therefore it should be resistant and recovered, I would think, but it probably either because of the tourniquet, it hasn't reached that. Do you apply tourniquets to your patients?
I do not. I avoid tourniquets.
That's to some extent surprising that even with Sugammadex that still they are not reversed to normal, but you can give higher doses. Sure.
You know, I'm saying the Sugammadex does turn it to normal.
Oh, I see. Okay.
But sometimes there's a discussion because they say they have the full train of 4 and Sugammadex is not required. And I say, I'm not seeing the stimulation I would expect. But as soon as Sugammadex is given, within a minute or two, suddenly the stimulation responds just as I would expect.
That's again because the normal side probably responds better and maybe the abnormocyte is, I really don't know why that is. But anyhow, it responds to succinylcholine. That's a good, yeah. So anesthetic consideration, I think it doesn't really matter whether they use intravenous or inhalation anesthetic. There is no evidence that this sort of injury causes changes in opioid response unless there are other comorbidities such as opioid abuse or obstructive sleep apnea. Obstructive sleep apnea makes patients more sensitive to opioids. And as I said before, avoid succinylcholine after 72 hours after injury and use of non-depolarizers, Acetylcholine or Vecuronium. In these instances, in your case, most likely Vecuronium is preferable. And of course, one has to assess the twitch monitor. One can use the ulnar nerve. Alternatively, one can use the forehead to stimulate the facial muscles, EMG recording, if the arm is not available. And finally, I just want to quickly mention that there are some non-muscular actions. Muscular actions include decreased muscle tone and decreased oxygen consumption, which is very useful in ICU patients. Muscle relaxants also bind to the alpha-7 receptor, which are constitutively expressed in macrophages and microglia, and that has anti-inflammatory properties. And patients who get muscle relaxants have a lower cytokine levels following the relaxant administration. And there is one report where administration of muscle relaxant prior to application of tourniquet reduces the ischemic perfusion injury following tourniquet application. That's something to think of and something you may want to use if you think there is ischemic perfusion injury because of the administration of the tourniquet. But you said that you are not applying tourniquet, and therefore probably that utility may not be necessary in your case. The anti-inflammatory property of non-muscular action of succinyl, non-depressive muscle relaxant binding to alpha-7 receptor reduce the inflammation. And I think that's the last slide. And thank you very much for this opportunity to talk to you. I'm happy to answer any questions.
Thank you very much. That was just the kind of information we were looking for. It helps me understand a bit better because I was stuck on the upper motor neuron versus lower motor neuron. And if you've vacated the motor end plates, you should have a much bigger response. But you've shown that simply disuse of the limb causes that same response. So now I'm sort of understanding why this is across all paralyzing injuries. So I wanted to get just the takeaway. So we saw the slide about spinal cord injury just forever thereafter, definitely in a cervical, probably in a thoracic. You should not use depolarizing agents. And then on to the other entities. If we're down to the cauda equina, or we have a brachial plexus injury, one limb, or the right arm, for example, has no nerve connections in it whatsoever, do you think that's still a hereafter, never give it again? Or do you think after the first 6 to 9 months, we should sort of be back to a more normal response?
I think after re-innovation, it should be back to normal, especially if that person is using the arm and has mobility. And
yeah, so this would be a case where they do not. They have not recovered, and maybe we're going in later on to put in a gracilis muscle or something because they haven't recovered. The arm has remained paralyzed for 6 months, no movement. Do we still have?
I would think that he would be still sensitive to succinylcholine for sure. I can't be sure, of course. You saw that not every patient responds to succinylcholine. So he has he or she has the propensity for hyperkalemia, and therefore best avoided. They may not respond if there isn't enough critical mass of increased receptor numbers.
Yeah.
But it's probably safer to avoid.
Now, after a certain time window in the lower motor neuron injuries, that muscle degenerates and undergoes fatty atrophy, and there's really not a healthy muscle any longer that I expect to be expressing acetylcholine receptors?
Unlikely. If it's all fibrous, then the receptor numbers are probably not that much.
Right. So I would think on those lower motor neuron injuries, there would be a window after which we should be safer.
Yeah. So can that be, one might argue then, in spinal cord injury, the muscle is now all below the level it's all fibrous, then can we give?
Well, that should. So in the spinal cord injury, you should have the upper motor neuron below the level, so it's all spastic. So it doesn't fibrose. It remains active but not controlled.
Yeah, that's a good point. Yeah, it's still spastic. Yeah, that's right. Yeah.
And so then on to the hemiplegic patient. So all of those muscles are spastic. That's going to persist for years and years. Is he also in indefinite stay away from these agents?
I would think so. As long as there is some paralysis and probably best to avoid that. Yeah.
Okay. So one of the faculty members that we worked with recently came in saying there were some new studies that told him that in certain of these patients, it was safe to do it later on. And I can't remember if it was a spinal cord or a stroke patient, but he went ahead and gave succinylcholine and everything worked out just fine. But it made me quite nervous because I've had these conversations a number of times previously. And I don't know what the new data was that he was introducing, but he...
I see. I would love to see the data. I mean, of course, there is so much of papers coming out and I could have missed it, but I would love to have, I'd love to see it. And of course, I closely watch this, although I moved away from this area and doing other things now, but I still have interest in, I'm in the pros of writing a review on this because muscle relaxants are extensively used in patients in COVID-19 time.
Yeah.
Just to ventilate them and because of that, I have actually reviewed and submitted the review to a journal. Hopefully, I'll hear from them soon.
Okay. Now, this has been very helpful. So just going forward, I think I'm going to return back to the no succinylcholine on any of my patients. And Vecuronium and Sugamidex will be the go-to combination, I think.
That's a safer way to do it, I would think.
Yeah. Perfect. Well, thank you so much for your time.
That's a pleasure, Dr. Brown. Wonderful, and wish you the very best. Yeah, it's a pleasure to talk to you.
Pleasure to hear from you. Thank you so much.
Bye.